Ed. I would like to introduce our first panelist, Dr. Icy Fergus Rowe, who serves as the Director of Cardiovascular Disparities at Mount Sinai Medical Center. Dr. Fergus Rowe.
Good evening, everyone. I'm so excited to be here. Thank you very much for the invitation. I'm looking forward to discussing a subject that is near and dear to my heart, but unfortunately, the ramifications of disparities as it relates to health, results in some pretty, damning sort of devastating outcomes here in the United States. So this is just an introduction, and I guess I will talk to you guys a little bit more later when the questions get asked. But thank you for having me this evening.
Thank you. Next with us, we have Judith Watson, who currently serves as the CEO of the Mount Vernon Neighborhood Health Center, Incorporated. Judith.
Good evening, everyone. Andre, thank you so much for inviting me to be a part of the panel, and good evening to my fellow panelists and everyone out there, and so grateful to be here at the table. I do have the solution, a part of the solution, but we'll talk a little bit more about that a little bit later. Thank you.
Awesome, awesome. Next, we have Dr. Byron McNeil, who serves as the Associate Dean for Clinical Affairs at SUNY Downstate.
Good evening, everyone. It's a pleasure to be here, and hello to my esteemed panelists. This is exciting and a topic that is near and dear to my heart.
Welcome, welcome, welcome. And with us this evening, we also have Mr. Anthony Trotman, who currently serves as the Deputy County Manager for Mecklenburg County, North Carolina, AKA Charlotte.
All right, good evening, everyone, and thank you for this invite for this most important topic. I've spoke to many different groups. I'm always happy to talk about this because I think as we spread the word and we talk about health disparities, as we talk about the issues, we will be more prepared for any additional pandemics or any additional issues that face us. So we need to arm individuals with this information that we're going to talk about tonight. And so thank you for the invite. I look forward to the conversation.
Thank you, thank you, thank you. So you know what, we're going to get right into it. And this question will set the tone and set the pretty much set the foundation for the evening. And it's going to be open to all of you that are with us here this evening. So to the panel, what are health and healthcare disparities and why do they matter?
So yes, if I actually may share my screen, I actually have a definition which we can actually maybe all speak to. People have maybe various interpretations of it, but a health disparity. So first, let me just say that Martin Luther King stated that of all disparities, inequities in health is the most severe and most, I changed it a little bit, but most brutal. Why? Because having health is an innate right. And if that is removed, then that is just brutal. So the disparity definition is a difference in health status, healthcare access, quality, and utilization that occurs based on social race or racism, ethnicity or ethnocentrism, gender or sexism, education, income, geographic location, elitism or disability, ableism, and is fundamentally unfair in policy design and practice. And I know that you're going to come to social determinants of health later on, but the bottom line is that health is a right. And in this country where there's so many resources, everyone should have equal access, and they don't. So I don't want to hog the floor, but I just love this topic, as I said before. So I'm going to stop sharing and the others can maybe jump in to add their thoughts to that definition.
Thank you.
And Dr. Icy, that was a really good definition. I think as we think about these health disparities, we also have to think about infant mortality. And in some communities, infant mortality is comparable to third world countries. As I look at some zip codes in our community and some zip codes in other communities that I've worked in and connected with, infant mortality was a real big issue. And as she just talked about, the social determinants of health that impact those health disparities is a real problem for our country. And as we look at what has happened over time with the pandemic, it all sort of ties in together. And so, having access to affordable health care, having states that have expanded access to the Affordable Care Act, is a real game changer for some. But even access, you have to have an appropriate medical home, and that appropriate education has to be provided for those individuals. And so our health disparities, despite the Affordable Care Act and many of the different initiatives that have come about, we still have some of the same health disparities that we had in the 70s and 80s and 60s because of those social determinants, those root cause issues that cause health disparities. So I look forward to talking more about the disparities as we get more into the conversation.
So I'd like to give a few examples of health disparities, right, that exist. And I think the most recent and the one that's in the minds of everyone right now would be COVID, and the fact that Blacks are contracting COVID at a rate of 2 times that of our white counterparts. Blacks are dying at a rate of 3 times of that of our counterparts. Blacks and Hispanics are disproportionately impacted with illnesses such as high blood pressure, diabetes, cardiovascular disease, kidney disease, asthma, and the list goes on and on and on. And the question is, why is that? And it's a complicated issue, and I'm sure we're going to get into it a little bit more. It's a complicated issue, but it's something that needs to be addressed. And my concern with regard to health disparities is because it's all about COVID right now. I think that people have forgotten that these other disparities existed pre-COVID, and those disparities have been further compounded and exacerbated as a result of COVID. So there's a lot to talk about with regard to disparities this evening.
Wow, wow, thank you. And as we continue talking about the definition, let me just take a quick moment to introduce the last panelist who has joined us for the evening, and that is Westchester County Legislator Ruth Walter. Welcome, who currently also serves as the chairperson for the county's Environmental and Health Committee. So Ruth, please unmute yourself and at least introduce.
Thank you and good evening. Andre, I'm so glad to be here and I apologize for being late. I was having trouble between my several computers here. And I hope at no point during this do my very loud dogs start barking because they are explosive. They're small, but they're very loud.
All right.
I'm so glad to be here and I'm so glad to talk about health disparities in Westchester County. I am the new chair of the Environment and Health Committee, and we began in September when I took over with the subject of Black maternal health. And we brought in experts from the midwife community, from General Sister to Sister International, Cheryl Brannon, and Nubia Earth Martin, who runs a new childbirth education center in Yonkers, the Office for Women in Westchester County, Robbie Schlaff, And we had a discussion about the fact that Black women die in childbirth 5 to 7 times more than white women in New York State, which is a huge crisis. And I appreciate what Judith Watson just said about the fact that we have healthcare disparities throughout our system that negatively affect Black and brown people. And we really do need to look at these reasons for that, systemic racism, substandard housing, things that are, preventable if we have the will to do so. And I'm so glad to be here. I am a learner. I'm not a medical professional, but I do believe that our health and our environment is something we all share, and that it is incumbent upon us to work to make those disparities lessen or disappear. So thank you.
Awesome. Thank you. Thank you. So with that being said, let's go on to the next question. And some of it were, some of the information in this question was addressed, but now we can go ahead and dive a little deeper. And what is the status of such disparities today? And we will have that for Dr. Icy. Please take this moment to address.
Absolutely, absolutely. And I'm so glad to hear what Judith Watson said, because as a cardiovascular specialist, I deal with hypertension, diabetes, heart failure, and of course, cardiovascular disease. And the lowest life expectancy for any person in the United States is the Black male. The Black male lives on average 10 years less than the person who has the highest life expectancy. And that is due to multiple things. And it's not necessarily due to incarceration or murders or anything or accidents. It's due to what Ms. Watson talked about, which are some of the comorbidities that lead to heart disease. Heart disease is the leading cause of death, being followed very closely by COVID. Of course, we know that COVID ended up being almost the third leading cause of death because of all of the people that were taken out. But you heard her quote some stats. And one of the reasons why Blacks are much more affected, and we talked about where you live and who you are, but those who have worse outcomes have what's called pre-existing conditions. And those pre-existing conditions are the same things that cause death for cardiovascular disease, which is hypertension, diabetes, renal kidney disease, and of course, having heart disease itself. There's another component, which is obesity, which is also part of pre-existing conditions. And Black women are likely to be the most obese among all groups. By the time people reach 25, it's already estimated that more African Americans are more likely to have hypertension. They get blood pressure earlier, it's more severe, it's less controlled, there's less adherence, and many doctors don't necessarily pressure people to take their medications. On the other hand, some of the issues may be related to people themselves, because there's also the lack of trust sometimes, right? And not necessarily wanting to maybe appear to be vulnerable. But I submit to you, you need to go and take care of yourselves, because not having health, of course, diminishes every other aspect of life. Thank you.
Anyone else care to add?
Well, one of the things that I would add to what Dr. Fergus Rowe just spoke about is just by her mere existence, right? By her mere existence, being a Black female cardiology specialist, that goes a long way towards helping with disparities. I think the medical community, I think that minority physicians account for about 2% of the population of physicians in the United States of America. And I think we all know that patients identify more with people who look like them. And I think that when a physician looks like you and understands the nuances with regard to your culture and the way you think and the way you eat and the way you work and the way you live, that goes a long way towards closing the disparity gap. But again, she is in that 2%.
I'm actually in the 1% because it's even more dismal when you're a specialist, and a cardiovascular specialist makes up 1% of all cardiologists, and even more so when you're a female. I remember one time, maybe about 10 years ago, they were counting that there were less than 100 board certified female Black cardiologists. So, you know, you're right, because they've done like a study with Black patients, with Black doctors and white doctors, and also with white patients. And the patients were treated very differently, depending on who saw them and what was seen as their, you know, social background. And even if the Black patients had higher education and more, maybe more economically endowed, some of the white physicians were still likely to not, you know, give the same level of treatment or whatever to the Black patients. So it's a systemic problem. It's something we have to work on. And I agree with you wholeheartedly. I really hope that, you know, we can get more of our youth to go into the fields of STEM and STEAM and medicine, because it's sorely needed.
Duly noted, duly noted. Would you like to add anything to that, Dr. McNeil?
Sure. It's amazing just kind of hearing everybody's story and also the input that everyone has provided for the discussion. For me, my experience with health disparities begins almost 3 decades ago, in that there are significant health disparities within urologic cancers, in particular prostate cancer. Prostate cancer tends to impact men from our community at a greater rate, and we don't do as well with treatment. And as a matter of fact, I lost my father when I was 15 years old, secondary to complications of prostate cancer, which shifted my life then and ultimately led to me becoming a urologist, believe it or not. These disparities continue to exist, but I can speak from the medical school leadership standpoint in stating that we recognize that these disparities have persisted over decades, and we're trying our best to train the next generation of physicians to recognize disparities and to work to eliminate them, whether they come from a, you know, typically underrepresented environment or not. So there are pipeline programs in place. We're doing things with local colleges. We're also doing things with high schools to encourage kids to pursue careers in the health profession.
Thank you, thank you. I actually have a follow-up, and I want to address this to Legislator Walter. When it comes to your role, and we're looking at the legislative process in regards to addressing some of our you know, disparities out there, where do you see, let's just say, we'll go ahead and say, the county, where do you see the county having some real input with this?
Thank you, Andre. I think that the healthcare system is really divided, right, among sort of wealthier hospitals and not so wealthy hospitals. It is true that even with similar or better education in the case of Black maternal health, Black women still suffer worse outcomes than their white counterparts, regardless of education or income. However, you know, we and the legislature do have a really big role to play at the county in community health, education, and funding. So, for example, my advocacy after we had that meeting was we put money into something that would enable low-income first-time mothers have home visits from a nurse up to 2 years before and after the baby was born. So we are trying to fund organizations with county contracts that go out into the communities and reach people who might not necessarily have a good connection to a doctor. And so I would like to expand that role for myself and for my legislative colleagues. And we do have legislation that can improve outcomes for all Westchester residents, including education on things like preeclampsia and outreach, so that people are understanding that it isn't, just a one-time thing, that it's a long-term process to shrink those disparities. And the legislature does have a role.
Thank you. Thank you. I want to turn the corner just a little bit because something just came up, and I have this common sense approach to a whole lot of things in life. Blame that on my father. But here we are in dead smack a year into this pandemic, right? We have the vaccination process going on as we speak. However, we have a segment of a population that doesn't want to do it, doesn't want to get involved, don't trust it. And I'm sitting here like, in order for a child, and I'm just going back to my childhood, in order for a child to, enter into school, enter into camp, they have to provide documentation that they had the measles shots, the mumps, rubella, like all of this. And then all of a sudden, now everyone's afraid of getting this shot, which, by the way, I did get my first one, and my arm was, yeah. But I was determined to go through this process because I rather deal with a little pain in the arm than the alternative. Why is it people are so afraid? And I want to give that first to Mr. Trotman because he is representing below the Mason-Dixon line right now. And I want to make sure that, this is a pandemic that has hit us all. And how is it that you are handling it in the South?
So I think, over this past couple of years, the politics have really caused a level of anxiety and stress that, people have stopped trusting government. And, when you lose trust in government, especially as we think about how fast the vaccine rollout happened, and then you have these images of what happened in the past with the Tuskegee experiment and several other things that have happened over the last couple of years. Think about it, over the last year, we have had a number of African-American men and women who have been murdered. There's been a number of protests, there's been an election, and there's been this 24-hour news cycle of negativity, depending on what's happening. So you take, all of these things, and then you say, here, take this vaccine. So for some who don't trust government, and I've been in government over 20 years, some just don't trust government, they don't trust the system. And depending on, who they're connected with, who their social networks are, they may not get a full understanding because of their education level or just their influence with their friends and or family. I think that's a big reason because, where we are right now, the vaccine rollout is happening. I mean, there's millions of shots that are happening every day. Mm-hmm. Many people that, want the vaccine have access to the vaccine. And if they don't, they will in the next couple of weeks. So, we have to ensure that, one, we continue to educate, we continue to have sessions like this, and hopefully, a number of people have got on to listen to all the experts around the table to see that if you just took it, Andre, and I took it and everybody else took it, then maybe it is safe. So I think, more positive press, more positive communication, more understanding, more education is what's needed in order for people to begin to trust government again.
Thank you.
Andre, could I just quickly chime in?
Please.
So let me say this quickly, right? So when the COVID pandemic hit, there were drive-up COVID facilities erected all over, right? Drive up, right? The population who are dying from COVID don't drive, a lot of them, right? And I'm thankful that at the Mount Vernon Neighborhood Health Center, in collaboration with the governor's office and the city of Mount Vernon, we were able to erect a walk-up, COVID walk-up, one of the first in New York State, so folks could walk up to get tested. Poor people don't drive. They take the bus, or they get a ride, or they take a cab. There was no transportation. So with regard to disparities, that is a concrete example of a disparity. So these are the people who are dying. They couldn't get the test. They don't have cars to drive to New Rochelle. That's number one, right? And thankfully to date, we've tested over 24,000 people, and we're testing about 300 people per day, right? You see the lines at the urgent care walk-ups. Our people can't get there. They don't have insurance. That's the first question that they ask. They need to come to us. They get the test for free. They get the result. They go home, right? Remember at the beginning, I said I have somewhat of a solution here, right? So that's one piece of it. And with regard to the vaccines, because we're vaccinating the community as well. For every one person who doesn't want the vaccine, there are 4 others who do.
That's
And
right.
Anthony nailed it when he said over the next couple of months, it's going to be available to everyone who wants it. But we're going to have to pay a lot of attention to those folks who are hesitant and fearful, rightfully so, justifiably so. We're going to have to pay a lot of attention to them. But my thing is, let's vaccinate the Black and brown people who want it, right? Let's get them vaccinated. And we're going to also deal with those who don't want it. And it can happen concurrently. That's it.
So if I add to that, I think that's an excellent point. But alluding back to what Anthony was saying in terms of trusting and understanding, there are people who have access who are not going. So so if you look at in New York City, in Harlem, where things are accessible by bus or train, and there are things that are closed, people are not going. And I've spoken to a number of people. That Tuskegee trial comes up over and over again. So just to break it down for the Kappas who may not understand the science behind that, that Tuskegee experiment was one done on Black men, okay? And it was Black men who had syphilis, okay, which was an STD. And the treatment for syphilis was penicillin. And they already knew that the penicillin could treat this condition, but they withheld the treatment. And the reason was so that they could learn about the stages of syphilis. Okay, so people progress from just having it being an STD to the very end, it becomes something called tabes dorsalis, where it affects your brain and then you're dead, right? So that has become one of the things that has been reverberated throughout. So in that setting, actually, it's not that medication that something bad was given, as what people are thinking is the vaccine, is that something was withheld, right? That could have potentially cured. So first we have to understand that. The second thing is we have to, and I love this forum, I'm glad that you have that, but we need to have more forums like this that people can actually understand what the vaccine is. A lot of people do not understand what the vaccine is, and because of that, they're reasonably afraid and they don't want it. They think it's the virus that's being injected, that the virus may take over their body. Others are saying, so why were they able to develop this vaccine so quickly in 1 year when it takes years and they don't even have a cure for AIDS or HIV? So the simple premise is this: the coronavirus has been in existence forever. Okay, it has different variants and it's well recognized. And not only that, it was being expected that there would be a pandemic. They already had, some experience with the Zika, with the Ebola, with MERS, and with SARS. MERS and SARS were coronaviruses, okay? So they already were doing a lot of research and were basically expectant of a new variant to come. And so coronavirus is just a new variant. It's the variant that came out in 2019. So they already sort of were, pretty far along with the research, but also because of the deadliness of how deadly this was. A lot of money was poured into finalizing, and the treatment for this vaccine. So just so you understand, what is the vaccine? Or at least, let's just say the Pfizer and Moderna, okay? Pfizer and Moderna is a recreated piece of protein, of the spike protein from the virus. So when the virus attaches to your cell, it's attaching to an ACE receptor, and that little spike attaches to that cell. So now this is being presented to you in a vaccine. The body now creates, if you look at it, an antidote to this protein, right? And then it destroys what came in, but it now has, like, these sentinels that are watching, so that if this virus, this particular particle or spike comes again, which is the virus, then the body is prepared. Nothing enters your nucleus, nothing enters your chromosomes, nothing takes over your body. It's simply now your body is able to recognize when this antigen shows up. So if people can recognize that and know that it's not taking over their body, it's not harmful, then maybe more people would be willing to take it. And we need to get that information out there.
Thank you, Dr. Ice. Whew. A lot. But now, to your point, before I go on to the next question, and I'll go ahead and say that this is a statement, and I won't put our county legislator on the spot. If our elected officials outside of Westchester, and I'll even say outside of New York, if elected officials took this pandemic seriously, would we be in the position we're in today?
I mean, I'm gonna say no. I think they really bungled it. We saw nurses with garbage bags trying to take care of patients. We saw the National Defense Production Act not being put into effect at the very beginning. We saw delay, denial, bad science, bleach being, promoted, or chloroquine, which was not appropriate. And I think it could have been handled so much better. And I think we have to trust science. We have to trust medical professionals. And that doesn't necessarily mean we know everything at the beginning, because we didn't know everything at the beginning. I remember we all thought it was not transmissible with, aerosolized. It was really believed to be on the surface of things. And it did take us some time to understand how it could be transmitted. So I think science does take time, but I agree with Dr. Fergus-Rowe that it was amazing how we put our information and our knowledge to use to create this vaccine. And it's wonderfully, quick, really, although we've had so many terrible deaths and loss. But we really do need to continue to promote the idea that the vaccine is safe and that it will protect you, will protect your family if you get it and you're not, bringing COVID home. So I do think we could have done so much better, and it really is a shame that we didn't have good leadership.
Thank you. Now, as stated earlier in the introduction, the reason why we are doing these panel discussions is pretty much to address components of that contribute to systemic racism. So I would like to pose this to all of you. Pretty much, how does explicit or implicit bias within the healthcare system that prevents adequate service to those in need impact how you treat or address the concerns of your patients or those you represent? I know that was a lot. Mr. Trotman, feel free, jump in.
I think explicit bias prevents some individuals from even seeking service. Because they don't trust. And then you have the implicit bias where people may not, prescribe certain treatments or prescribe the right treatments because they don't think that, some individuals will actually follow through. That is combined with, lack of insurance, depending on, the person and, their background. And so certain things are not prescribed. So either you don't go or you don't get prescribed the appropriate treatment. And that's on both sides. I think that contributes to, some of the issues that we continue to have today.
And I could add to that as a physician, because I see that all the time. I think Ms. Walker was relating to this, and one of the issues with maternal fetal issues is that there's actually literature out there that shows that people think that Black women are able to withstand more pain, and so that certain drugs, pain meds were not being given to them, or attention was not being paid to them. And so that by the time people recognized that there was danger or, something going on, it was too late. So that's definitely in the maternal space. But I can tell you also, when it comes to just people in general, I remember as a resident or chief resident, when a person with sickle cell comes in, right? They have pain. You need to treat the pain. But people would automatically assume that just because you're Black, and sometimes especially that you're a male, that you're drug seeking, right? That you really don't have the pain, right? So instead of trying to give you something to reduce your pain, like a narcotic or something like that, they will withhold that, thinking that you're drug seeking. So what happens? That person gets sicker and sicker, and it becomes a vicious cycle. They may give something that doesn't necessarily, reduce that pain. So it leads to other things, because when you're in pain, your blood pressure is going to go up, your heart rate's going to go up, and now it becomes a vicious cycle, and you're not getting better. So I submit to you that there needs to be training. The government needs to be involved from a higher level, but there needs to be training for your healthcare providers to recognize that every individual, every patient should be treated as a unique individual, and there shouldn't be a blanket expectation just because you're Black, you're drug seeking, or you have a higher pain tolerance, or there's nothing, really wrong with you. So that is definitely an issue as it relates to implicit bias, and I've seen it in the works.
Okay. Okay. Anyone else would like to contribute?
I always listen when I always listen very carefully when this question is asked, because it's such a complex issue. It's such a complex matter. And there is no silver bullet. Like, there's no easy way to answer this question because it's so complex, right? So even in an organization like the one that I have, I'm able to manage, I have the honor and privilege of managing and leading, where we have predominantly minority providers, physicians, mid-level providers. There are biases. They have biases just like any other provider. Do you know what I mean? They do. They do, right? We have a lot of, for example, we have a lot of folks who come in from the Caribbean. So say, for example, our African-American providers, they have some preconceived notions with regard to these Caribbean folks and, the nuances. And it is such a complicated and complex issue. And God help us. I think together we'll figure it out. I agree with everything that everyone has said, and I always do. I agree with everything that everyone says, but there's so many, it's so big. And I think that we need to acknowledge that as a society. This is a huge problem.
Yes.
And it's gonna take the entire village to resolve it.
I agree. And I'm trying to move this along. I have a statement in the chat box, and it's interesting. And I will lead off with this. In the past day or two, and hopefully I won't be put on blast, but for the past day or two, I was corresponding with a colleague something had occurred and they're looking for some advice. And I'm like, well, why don't you what you need to do is get in contact with the specialist. Oh, I don't like going to doctors. My response, of course, was, all right, we're not getting any younger. You need to take your health, real seriously. But then, you tie that, you take that, Dr. McNeil, and the statistic around Black men and the high mortality rate. What can we do as a community, as a village, to further ensure that Black men and just men of color take their health more seriously? And, I listen to my body. I have my doctor, I have my physician on speed dial. So if something doesn't feel right, I'm calling them, but that's just me because I'm trying my best to live as long as possible so I could agitate as much as I can while I walk this earth. But what can we do and what can be done so we can take our health more seriously so we can bring that mortality rate down a little bit? You need to unmute you. Are you speaking, Dr. McNeil?
Yes. Yeah, so there's several things that we can do to kind of move this forward. And I think the first thing that we have to do is we have to become more comfortable having uncomfortable conversations. And I take this back to the barbershop. When I was going to the barbershop when I was a kid with my dad, I heard so many tall tales that I just thought that lying was normal. Lying about how okay we are, lying about how good we're feeling, lying about what we have going on. And that, sort of takes away from our truth. And I'm also going to highlight something else. We talk about physical ailments. And one thing that this pandemic has highlighted is the number of us suffering with mental ailments, whether it's depression, anxiety. I mean, a growth in mental health treatment is one of the greatest things that can come from this pandemic, if it hasn't already. So I think that where we start is we become more comfortable having those uncomfortable conversations.
Anyone else would like to chime in?
I'll just say that I think going to see a physician and not necessarily knowing what's going to happen, I think does cause a lot of anxiety. They might order a test and you're not quite sure what the results are going to point you to. You might get bad news. And, I had breast cancer about 10 years ago, and nobody wants to be in that position, right? But I'm here, and I think that when you think about treatment for things that maybe you need to get checked on, I think the issue, to your point, Andre, is to trust that things that are treated will ultimately get you to a good place. And I think that our relationship, most of us with doctors, can be one that is fearful. Nobody wants, bad news. However, you really can get to the good outcome if you trust your doctor.
I think the other thing is that, you look at going to the doctor or getting medical services as any other item that you're consuming, right? So you do go to the barbershop, you want to look good. You go to the department store, whatever, you want to look good. But you go to the doctor because you want to feel good and be good and live longer, right? And you find somebody that you're comfortable with. You're not going to go to a barber that you don't like or you don't trust or who doesn't do a good job. So I think that is a problem with many people of color that I see, is that they'll go into the doctor's office, they may have a bad experience or they may not understand what's going on, and they're done. But they really should look and be consumers. You're paying for the visit. you have insurance, well, those people who have insurance, but you cannot be turned away. For even those who don't have the so-called commercial insurances, they should be treated like anyone else. There shouldn't be any, preference. So if you need to have a cardiac cath, or you need to have a procedure that's expensive, it just needs to happen. Now, and here in many of the states, they do have something that's called get with the guidelines. So a lot of medical institutions are now ensuring that that happens. But Anthony, in your area and in the South, there are a lot of Black men who cannot get a procedure. They cannot be referred, not being referred for a cardiac CT or a TAVR. A TAVR is a procedure that replaces your aortic valve. There's disparities surrounding that. Even though Black men are more likely to have problems with their aortic valves as they get older, they're less likely to be referred for this life-saving procedure. So I think that if you're not getting the answers, there are answers out there, and there are organizations that can help for all of the conditions you have. The American Heart Association, the Association of Black Cardiologists, all of the specialties have, organizations. So if you are not feeling it with your doctor, reach out to the organization and ask for someone, or you could report also. People feel empowered, to take, care or take charge of your own health. And, and actually engaging in your health is more empowering, right? Because now you can really enjoy and do everything else that you want to do because you're feeling better and will live longer.
The only thing I would add to that, and I love everything that's been said, the only thing that I would add to that is their wives and sisters and mothers and cousins and friends and girlfriends, and there are 3 men on this panel, right? Well, Andre, you're the moderator, but right? So there are 2 other panelists than you, Andre. And we're drilling this into their heads, but for some reason, it's not resonating, right? So I say we start with the youth. I say we start with the youth and we figure out a way to get them comfortable with going to see the doctor at a very young age and being comfortable in that setting. We have school-based health centers at the health center, but that's another conversation. But we have to, I don't want to say forget them. I want to start with the youth. Get them comfortable with going to the doctor early on in life, so that when they become adults, all of these wonderful resources that the doctor pointed out and everyone's pointed out, these resources are there. There's an abundance of resources. The men aren't taking advantage of these resources. And by the way, it's Black and white men, for the record, okay? But we're focusing on Black men. But I say, start with the youth. It is so fresh. Start with the youth.
Well, let me give you guys a joke. Like, if you're, to your point about having a partner or a wife, there are statistics about that too, right? So I speak about women. So get this, guys, listen to this. For a woman who is unhappy in a relationship, okay, they are more likely to have cardiovascular disease and death. I quoted to you, it's called the Stockholm study. But guess what? For men in a relationship, whether it's unhappy or not, right? Their lives are prolonged, right? But, and that's because probably, as you said, Ms. Watson, is that their significant other may be making them go to the doctor or making them do that. But so it's good for men, quote unquote, to be in a relationship, and that's the Stockholm study. But to your point, if and we don't probably have a lot of the wives or spouses listening in, but to your point, if you have a partner or someone who can really help to talk to that person, then they may be more willing to go and get checked out.
I'm not going anywhere near that.
It is a true study, though. Look it up. It's called the Stockholm study.
Love that.
Wow, that's awesome. Thank you. So this is just some real important information. But I want to go back to Dr. McNeil and what he said about one certain topic, because it's near and dear to me. I have the privilege of serving on a committee on a national level for my fraternity, which is health and wellness. And it's, of course, I am the only one that's not a degreed physician on this committee. But the reason why I'm on there is because I was adamant about addressing mental health and men of color. A few years back, the world life was giving me body blow after body blow, uppercut after uppercut, and I was ready to cash it all in and say, you know what, I don't need this stuff no more. I just don't. But then for some odd reason, I decided to seek alternative resources. And one of the challenges that I experience, and quite a few are experiencing today, is finding those in the mental health profession that we can relate to. One, that we can relate to, and then two, that we can afford, because we find out that most of them aren't taking insurance, but they are there still to provide a service for us. But it is a challenge. How do we address that? Dr. McNeil, anyone, how can we address finding those mental health care professionals that look like me, that look like Dr. McNeil, that look like Mr. Trotman, that we can relate to and that we can afford?
So it is incredibly hard to find mental health professionals that look like us. They do exist. I know several of them, and some of them have, they do not accept insurance, and they sort of run cash-only businesses. However, there are those out there who realize how important they are to the community. And some of them will sort of provide services on a sliding scale. Mm-hmm. Case in point, I know a therapist whose rates may be $275 an hour or so, but they do see some patients for $50 or $75 an hour. So there are some of those out there who do provide services at a discounted rate because they believe that it is important for our community.
Awesome.
No, I think, as we elect individuals to office and they run on a certain platform, we have to define what's important to us. And we have to hold, those elected officials accountable to invest the tax dollars appropriately. We know, as we talked about the social determinants, that access to healthcare or access to mental health care is extremely important. And really understanding, the adverse childhood experiences that boys, specifically African-American boys, have experienced over time because of the lack of fathers in those communities where the health disparities exist the most. It is a real problem. And without recognizing those adverse childhood experiences, they go untreatable for a number of years. And then till that person breaks. And we have to treat it just like we treated the pandemic. We have to put the necessary resources to this problem because we know this problem exists. Study after study has shown the level of trauma and stress in these communities where the disparities are the most, but yet we continue to employ the same type strategies. And then if the father is not there and there's a number of children in the house, education budgets have been decreased as well. And so the home economics programs that were offered in schools at one point are not offered. And so understanding health and, how to actually maintain yourself, it doesn't get taught. And so now you're an adult, you're attempting to find a job, but you can't really regulate yourself and you don't know why, and you don't have access to treatment. We have to put more money into this area in order to improve the outcomes, in those disparate communities.
Wow. Thank you. Thank you. Let's see here. I do have a question, but before I pose this question, I want to take a quick poll. We have a few more minutes before we close out, but I'm pretty sure that it should be some very interesting feedback. If we can just launch this poll real quick, everyone should be seeing it. We have 1, 2, 3, 4, 7 quick questions. And while that poll is taking place for the panelists, I'm just giving you a heads up. The next question is going to be focused on the topic of Medicaid. Okay, we have about 30 more. Hopefully we, within the next 15 to 30 seconds, we can close this poll out. We have 45, 40, 50%. Okay, all right, all right. Awesome. 63%. All right. Some very interesting questions in regards to how healthcare is perceived and throughout our lifetime here. All right, can we get to 70? Oh, yes, we got to 75%. I greatly appreciate your participation. Awesome. We're almost at 100%. Unless people are logged in and they kind of stepped away a little bit. That's all right. All right, we're gonna close this out in 3, 2, 1. Thank you. Wow. Wow. I'll be sharing that momentarily. Okay, next question is, this actually came from a healthcare professional that's actually a member of our chapter, who is currently out in Texas right now. And his question was, we find that a lot of patients on Medicaid have a difficult time finding primary care physicians in their areas due to physicians not accepting Medicaid. Most of these people are minorities or the underserved and vulnerable and come from lower social economic classes. How is this, or how can this be addressed? And I'll leave that open to anyone who would like to tackle it first.
Okay, so with regard to Medicaid, there was a time when private practices were not interested in clients with Medicaid. Those patients were reserved for us at the health centers, right? No one wanted them. But now, because it's all volume-based and the larger practices are able to negotiate better contractual rates, reimbursement rates from the insurance plans, they'll accept just about anyone, right? So that's into primary care, right? Specialty care is where it becomes more challenging, right? If one of our providers needs to see Dr. Fargus Rowe or maybe Dr. McNeil, right? That's when it becomes challenging, is to try to get to a specialist and forget subspecialists, right? So and the other thing with patients with Medicaid, again, as long as your Medicaid is active, you can probably see a primary care doctor. The problem with Medicaid is, unlike your insurance or maybe my insurance, folks with Medicaid have to recertify every couple of months, right? Every 6 months to a year, they have to submit documents to recertify. As a result of that, it's a stringent requirement for a lot of our patients who are moving around, transient oftentimes, that insurance gets dropped. So there's a period there where folks are uninsured. You see? So those are some of the challenges that comes with Medicaid. It's not like your insurance. You're insured, and as long as you're working, you have the same insurance, no problem. It changes for the population that we're speaking of. So that's my little spiel with regard to Medicaid.
In generally speaking, and I know we don't have a lot of time, It's 8 o'clock, but there are studies that show, especially for the specialties, and I have the slide. If I had time, I could have pulled it up. But let's just talk about the life-saving stents. You know what's a stent? If somebody has a blockage and they're having a heart attack. So they've done a meta-analysis looking at people, and they divided them into having Medicaid, Medicare, commercial insurance, and gender and race. And they definitely found that people who had Medicaid and Medicare were not as likely to be referred for a stent, which is life-saving. Okay, and that is definitely a study. And so, but based on that, and I would say that most of the institutions here in the Northeast, there are regulations that prevent that from happening, but small private institutions and elsewhere in the US, it happens. I know that also the insurance, you know, just the drugs that are out there. If I tried to give somebody, you know, a life-saving drug for the heart, right? A brand new one that comes out, Medicaid and a lot of the subspecialties of Medicaid, they're not paying for the drug. You know, so what ends up happening is that person is not going to be getting, you know, some of those, you know, newer and better drugs that are out there. And that's just a fact. So I think that the government and, you know, needs to jump in. You know, we need to have more legislation that addresses this to ensure that people who have Medicaid and Medicare are able to get the treatments and interventions that is afforded to those with commercial insurances.
So I used to work for the state Medicaid program in Ohio for 5 years, and I was over provider enrollment and provider relations and all of that. And I would say government, you know, not just in the state of Ohio, but throughout the country, it's not really set up to be efficient as it relates to service delivery. It's set up to be accountable to taxpayers first. And based off of who's elected to office, you know, they have to make certain decisions to raise taxes based off of the number of covered lives. And if they're unable to raise those taxes, the Medicaid program has to recommend to the governor a balanced budget. Thus, that balanced budget means lower rates to go to those providers, and then those providers have to make a decision. Do I want to, you know, pursue high volume numbers in order to make the same amount of money that I would make with commercial insurance at a lower volume and better quality outcomes? And that's an issue. Now, with the Affordable Care Act and some of the changes associated with Medicaid, it's a little bit more efficient than what it was. Depends on the state that you're in. But it really is about goes back to those social determinants and the value that those providers, the value-based payments that those providers seek. You want to make sure that a person is not just healthy when you come into the office, but they're healthy when they go back into the community, so that they would reduce the overall cost of healthcare, which means the Medicaid dollar can go further.
Thank you. Thank you, Anthony. And the question that just came in regards to the Affordable Care Act, does it address some of these Medicaid shortcomings?
I would say it does, specifically now with the American Recovery Act, the Biden bill, for states that want to expand coverage. The federal government will reimburse those states, I believe, up to 95%. And that means the states only have to put in a small portion of the amount. And there's you know, standard programs, and then and this isn't the proper terms, but there's the standard programs, and then there's the optional programs. So some states, depends on how much money they want to put into the program, can opt to add more pharmacy benefits, more specialty care, higher reimbursement rates. And if the state puts the tax dollars to it, they can actually raise the reimbursement rates for their providers.
Great. Well, here it is, 8:05. I know we're a few minutes over, but this was just some valuable information, some valuable input. Legislator Walter, you have some information that that you can take back to your committee. And look, we need to work, all of us need to work on this. I just wanted to say thank you to each and every one of you for joining us. And thank you to, especially to our panelists that gave some interesting stories, some valuable information that will better, hopefully, prayerfully, better assist us as we continue to live healthy and make the right decisions for ourselves and for our family, for our respective families. As you know, once again, this is systemic in practice and in nature in dealing with this country. So we need to make sure that we do address, these components so we can truly realize the quote unquote American dream. We thank once again on behalf of the Social Action Committee of the Rochelle-White Plains Alumni Chapter of Kappa Alpha Psi Fraternity Incorporated. We just want to say thank you for taking this time out of your busy schedules to share and impart some of your knowledge that will definitely better our communities. Join us next month, April 27th. April is actually Fair Housing Month. So April 27th, we will be focusing on fair housing. And thank you. Have a blessed evening. Continue to stay safe. Get the vaccine. Get the vaccine. Get the vaccine. You guys, thank you for everything. To everyone in attendance, thank you for your participation. This was wonderful. Thank you. Thank you.
Thank you, Andre. Thank you. And great meeting everyone on the panel.
You
Ruth,
as well.
I will be in touch.
Yes, we need to
Thank you.
talk. Nice
All
to
right.
see you.
Great to
Bye,
see you.
Andre.
Great
Take
to meet you,
care.
care.
Dr. Ferguson. Bye, everyone.
Thank all of you. Bye-bye.
All right. Bye-bye.
Lovely to
care.
meet you.